Michael, welcome to the podcast. I'm super excited to work with you today, man. For people who aren't familiar with you and all the amazing stuff you're doing in the space, especially around BFR, would you mind filling them in a little bit about who you are and all that you got going on, man?
Yeah, much appreciated, Dan. Thank you for having me. My name is Dr. Mike MacPherson. Done quite a few things leading up to this. Was an educator, worked in the operating room as a sports med surgical consultant. That's what really led me to the BFR realm. I'd be sitting in surgeries, ACL reconstructions, femoral acetabular impingement, and just wondering how I would rehab based on the graft they would take, what's going on. Ended up getting a call, started learning more about blood flow restriction. And once I started digging into the literature, it was no doubt just something I knew more people need to know about. If I didn't know about it and everything, NSCA, CSCS, been to state conferences, regional, national, I got to get the word out. So I just went to work, got in the literature, realized the need for education, built out an education platform, became a BOC approved educator, as well as an approved educator with the American Physical Therapy Association. And so we've got some certifications. Yeah. And just, I would be talking, what really stimulated, I'd be talking with all these, professional teams, especially the soccer teams, the academies, and they'd be using BFR heavy with their primetime athletes. My biggest question was, well, why are we using it with everybody? Why isn't everyone benefiting from the download weeks, the taper weeks, the recovery? Like they just don't know. They haven't been educated. They're not getting in school, or they're getting it for like an hour in their program. Like, we need better education. So that's what really stemmed me to dig into the literature, um, start to develop this education, this classroom, this unique thing I've created. And then while doing that, it's like the aha moment was like, whoa, we're focusing on athletes and ACLs. This could be for a lot of people, right? The longevity factor, the grandmas, the grandpas, the moms, the dads, hugely helpful for them. Shorten time in the gym while still increasing muscle mass, strength, and that longevity.
Absolutely. And while not planned, you mentioning about the role on the OR side of things, that made me think of one of the earliest and just to me most common sense applications that I was using BFR for is we started getting a lot of athletes preoperatively for physical therapy and rehab type of things before they would go in for those surgeries. And one of the things that I think really impacts athletes recovering from that surgery is the amount of time that tourniquet is left on the leg. And I'm not an orthopedic provider by any means. I don't pretend to be one, but it's been discussed, and we even did a discussion about that on the podcast in the past. And some surgeons only hang the tourniquet during the graft harvest, so 10 to 15 minutes, it's off. Others have that on during the entire duration of the procedure, which might be 30 to 40 minutes, might be significantly longer. I've seen tourniquet times as long as 90 minutes. So you think about what that feels like to have a BFR cuff on your leg for 90 minutes consistently. It gets a little uncomfortable eventually. But then you think about it, if you're not prepared for it, and that's the first time you've ever had that level of pressure. And oh, by the way, like, we're also doing a major surgery that you're going to have to recover from. Like, I think that anecdotally, athletes did a lot better when we did BFR with them preoperatively, and they were more prepared and had an easier time recovering afterwards. And again, it might be something totally different than the tourniquet effect contributing to that, but anecdotally, I see so much benefit to doing that. And I just ask myself, like, why is not everyone doing this preoperatively? Because it's a game changer, in my opinion.
Yeah, I'd like to add to that two things. I remember being in ACL reconstructions, and they put that surgical tourniquet on, and you're spot on. Some guys will just have it during the graft harvest. 90 minutes is gold standard tourniquet time, and that was last time I checked a couple months ago on tourniquet.com. Um, so you can have complete occlusion for up to 90 minutes during a surgery. So that always gave me reassurance. 5 minutes on, 5 minutes off. Typical recovery for athletes. Like, well, or with anybody, right? We're well within the safe ranges. If they're safe and approved for surgery, they can perform BFR. I recently had, I'm working, so I do a lot of sports performance stuff. We focus on closing the gap. So I own a small gym here in St. Clair, Michigan, and we're a sports medicine, sports performance training facility. And so one of the things we focus on is closing the gap between PT and full function. So that's a big focus of ours. And then just general sports performance, getting these athletes, bringing them a high level of training So it's not just bench, squat, deadlift, same thing each and every day. I recently had an athlete. I worked with him in the summer, and he came to me. He just tore his ACL, non-contact tear, planted, tore it. My first thought, I was like, "Here, take the cuffs." Gave him a pair of cuffs. I was like, "Take them with you." Mom, 5 on, 5 off, 3 cycles, once a day. He tore it 2 weeks ago. Everyone he's seen, his surgeon, his PT, everywhere he's stopped along the way, they cannot believe he has not had any atrophy that's noticeable to the eye post tear. And his mom, we were talking yesterday. She's like, I think it's the passive BFR. That's all they've been doing. And just like you're saying, a way to audit that prehab aspect. That's one of my big things. I remember playing college football, running back towards ACL. I remember in jumping rope and squatting before surgery. It's like the stronger we go in, the stronger we'll come out. And that's the big focus with this young man is just keep running that passive cycle. Let's stay strong so that we have great outcomes.
Absolutely, I could not agree more, and I think a lot of that comes back to the mechanisms of BFR, from the neurovascular effects to the actual effects on the, endocrine side of things and the growth factors and other releases that are seemingly, released in response to BFR that way. I think for the longest time, and I still have a little bit of this belief to myself that way, I used to think that it was all about horsepower, right? Build a bigger muscle, more hypertrophy, and obviously BFR helps with that, but also you consider the neural structures that supply the muscle. You consider the vascular structures that feed the muscle and help eliminate the waste products from the muscle and all these other things that contribute to the performance that we're after. And it's like, it's no wonder BFR works so well because it addresses all of them, not just one, not just two. It literally checks all of the boxes that are needed. And I think that's the other piece that I see so much benefit from this in the pre-op population is it's like, hey, we're not just accounting for the occlusion effect in the surgery. We're not just accounting for the atrophy effect following injury. It's like we're checking all those boxes and then some, all in one intervention that you can do, like you said, at home. I think the direct to consumer market for BFR cuffs is exploding right now, and for good reason, because the stuff freaking works. And it's like, if this is as effective as it is, and it's natural, by the way, this is not something that's going to harm you to the level of PEDs or that sort of thing. Again, I want everyone to be using it. I think it's appropriate for all age ranges and across the lifespan that way.
Yeah, I got safety studies that support from 12 to 88 years old. Different use case for BFR. As you said, right, the endocrine effects. What drives BFR? Three things: hypoxia, right? We're reducing oxygen in that limb. Mechanical and metabolic stress. Those are what we're creating with BFR. And those three things, they trigger, right? So there's a stimulus. What do they trigger the human body to do? They trigger our physiology. They trigger the release of hypoxia-inducible factors, which are master regulators in the human body. They turn on brain-derived neurotropic factor production, which is neuroprotective, right? Now we're protecting the brain, the nervous system, all those neurons. It turns on vascular endothelial growth factor, which is going to create angiogenesis. What's that? The growth of new blood vessels, right? So now not only are we getting muscles bigger, but now we're supplying them with the gas they need to actually function appropriately. Huge cardiovascular effects. Also, heat shock proteins are going to go up in response to hypoxia, which they're just old they do, right? They're checking off the structures and make sure everything's being built appropriately, properly. They're sometimes called longevity proteins. And then with those mechanical metabolic stress, those are our big endocrine factors in my mind, or which you commonly see in literature: growth hormone, testosterone, insulin-like growth factor. And we always think, I always do at least, first thing it comes to my muscle protein synthesis, we're going to get bigger faster, for sure. But it also has a healing effect on connective tissue. I think that's something that can't be stressed enough. Ligaments, tendons, inflammation. It's going to help heal those ligaments and tendons, and also calm that inflammation down, reduce swelling, and then that analgesical effect, right? That pain, that's going to disrupt that pain signal. So you're going to see a reduction overall. BFR for low back pain, lower body BFR cycling is absolutely unbelievable. If anyone is suffering from lower back pain, I can't help me. I had 2018, MRI, L4, L5, L5S1, both discs were herniated. They're talking about disectomies, this, that, and the other thing. Changed the way I trained because I felt like I trained myself into those issues. Did change the way I trained, but then also I started adding BFR with some cycling to it. um, absolutely changed the game. You could feel like the release in that lumbar fascia, just a relaxation effect.
I think it's important to note that training with BFR is still extremely rigorous. I think a lot of times people that haven't done it before, they look at it and they realize, oh my goodness, the load is like significantly lower than I usually use. There's no way I'm going to get the same benefit. And then they do it and they're like, holy smokes, I'm like, I'm on fire right now. I did 5 sets of 15 and my biceps are freaking blowing up and burning like crazy. It's very rigorous. And I think one of the most unique applications I've used it for, especially in that post-op lower extremity population, is the conditioning effects. I see so many athletes, and I've seen athletes in the past that get 6, 8, 10 months post-op from some of those different procedures. And they tell me they feel they're not in shape. They're not ready to go for sport. And that 100% changes what we do, right? They might look great on all the hop tests and the knee strength and all that sort of thing. But if they don't have the conditioning component required to return to practice, are we okay returning them to practice? Maybe, maybe not. I think that using BFR early on, even with some simple things like, if you're 6 weeks out from an isolated ACL injury, I hope by that point you're walking with a pretty normal gait, and I hope you're able to spin an exercise bike. If you can do those two things, throw a BFR cuff on there and watch the endurance gains go through the roof. And even if you're on the healthier side, the non-injured side, the amount of times I've read studies that show insane VO2 max improvements with
Yeah.
VO2 walking,
Yeah.
I'm astonished by it. I'm like, why is it that this is not being done by every endurance athlete? Because I think the low hanging fruit nature of it, right? BFR and walk, BFR and spin a bike. It's so simple and easy to do and fit into the day, and the benefits and effects you get from it are just astronomical.
I couldn't agree more. And that's one thing when I speak with a lot of physios, physical therapists who are working with, you commonly get BFR athletes and ACLs. So really trying to broaden that perspective, that outlook, start talking to physical therapists about working with the elderly. And that's the first thing I go to. Let's do some BFR walking. Let's do some BFR cycling, low pressures. We don't got to go very fast, but we're going to see a major, major difference and you're right, their aerobic capacity. They're going to see very significant strength and mass gains in a short amount of time.
Absolutely. Yeah, I think there was a study done in 2024, a meta-analysis that recommended for the from a parameter standpoint, if you will, looking to do something aerobically 2 to 3 times a week with the BFR on for 10 to 45, 10 to 60 minutes per session. There's a lot of variability. They recommended obviously repeating that over a period of weeks. Does that generally align with the kind of recommendations that you give from a parameter standpoint to someone who comes to you and says, "Hey, look, Mike, I want to improve my VO2 max. I want to improve my endurance capacity with BFR."
So I think, right, there's always that leeway depending on are they older? Are they a professional athlete? Are they, just a weekend warrior? But guidelines 40 to 60% LOP, low to moderate pace, 10 to 20 minutes. 2 to 3, I would like to shoot for 3 times a week, I would say is ideal. But yeah, just following those guidelines. Now, I have had a lot of recent feedback. Some of our collegiate programs, they really are liking the 60% LOP right now. They find that the athletes are much more tolerable of it, and they're excited to come back for BFR instead of using 80%. They're like, get this off me. I don't even want to do it. So their increase in buy-in, and to me, that's huge, right? If they're not doing it, there's no benefit. We have to get them to do it first, right? We got to set that hook. So they're having a great success at 60% LOP, and they're not seeing any differences in outcomes, right?
And
Like,
nowadays to get that 60% LOP, like the cuffs, most of them auto inflate. It's like you just hit the button and sit back. You don't have to sit there with the little manual pump. Like I brought when I did a guest lecture on PFR at Messiah University back in the spring, I brought my automatic ones and then I brought my manual ones and I let them try them both. And they were just like, I like these automatic ones so much better. It's like literally set it and forget it. It's never been easier to hit those numbers and metrics that you mentioned.
you're spot on, quick, convenient, and I'm a big believer if you're using the rehab space or just for dialing it in for accuracy, for progressive overload. I want to calculate that LOP, that minimum occlusion pressure, and then I want to be able to set that pressure so that I can vary it, right? Uh, am I fresh today? Am I a little beat up, right? I'm going to vary that pressure, make those adjustments, and I know what I'm at each and every time. I like to use what I really like about air bands, BFR, and I use Saga as well, is at the end of each session, it gives me a readout. What was my average pressure? What was my peak pressure? What was my minimum pressure? And a total time. I take a little screenshot, and I'm a big data guy, right? So I like to track all my lifts, track everything I do. So that always lets me know this is where you're at for BFR that day. And so when I come back, right, that following week, higher, lower, where's my benchmark? Where am I improving? Where am I not?
Yeah, no, that's awesome stuff, and as you were talking, I realized I was having flashbacks to the podcast we did earlier this year with Warren Bradley, also about BFR, and one of the big things that he brought up on that was BFR for recovery following activities that way, right? Athletes, they like to redline, they like to push really hard, that sort of thing, and I was thinking about those BFR walks or BFR bikes, and to me, that would be probably just as effective as passive BFR from a recovery standpoint, as I think there's a lot of benefit that comes from just getting up and moving for 15 to 20 minutes. And I think the low intensity nature of something like walking or just easy spinning a bike with BFR, I would imagine that helps to accelerate the recovery stimulus as well, just like a passive BFR would, I would think.
Yeah, spot on. And that's where we see a lot of our professional teams. They'll do passive or active recovery. We talked about it earlier, right? The three driving stimulus: hypoxia, mechanical, metabolic stress. When we're doing completely passive BFR, we want those higher levels of occlusion. We need them because that's how we're going to create that hypoxia, that mechanical, that metabolic stress. That's why you see so often 100% LOP with those high level athletes. If you're doing active BFR, right, active recovery on a bike or a walk, we can bring those pressures down because we have the exercise. We're not relying on just occlusion. We have that exercise to help create that hypoxia, mechanical, and metabolic stress.
Absolutely, and I realize so far we've kinda talked about BFR in relation to a lot of the lower extremity types of things, which that's personally where my practice mostly focuses on, hips, knees, ankles, and I think, for a lot of the field sport athletes, those are the things they hear about the most, but obviously, there's the overhead athlete population as well, from your swimmers to your tennis athletes, pickleball to a certain extent, baseball, softball, all these different sports that also could benefit strongly from BFR. It's just, it looks a little different, I'll say, because it's arm instead of leg. Do any of your parameters from a conditioning standpoint change if we're talking about using BFR in the upper extremity compared to the lower extremity? Maybe like some kind of like upper extremity bike or something like battle ropes or something like that. Maybe this is the athlete that's, a week out from their ACL injury. They can't do anything with their legs conditioning wise yet, but hey, we want to get some kind of conditioning stimulus in using the arms.
Yeah, absolutely. Have seen it. So BFR is systemic, as you know. So we'll see even people with upper body injuries, they'll still do a little lower body BFR. However, that upper body BFR, one of the biggest things I think people are missing, if you got tightness in the shoulder, the upper back, the traps, upper body BFR does absolute wonders for releasing those muscles and calming them down, improving that mobility. I had a wheelchair bound PT. I was at a sports medicine clinic at Denver, and he told me that they put him on opioids. They put him on quite a few different prescriptions in an effort, he tried all these different modalities to try and relieve some of his head and neck pain. And he told me that upper body BFR was the only thing that ever got rid of it. That to me is I've hung on. I mean, that was years ago, and it's like that really resonates. So I always recommend that. Um, Upper body wise, because we're a little bit leaner, it's still generally, you'll see it 40 to 60%, 40 to 80%, but most people are living between that 40 to 60% range. If they tolerate BFR really well, like I'll take myself up to 80% on the upper body because I do it all the time. But for more often than not, most people, 40 to 60% range for the upper body, they're going to get everything they need. They're going to get a great pump, and it's going to be a little more comfortable for them in the long run.
Absolutely, and just thinking about some of the different hemodynamic type things we see up there, like for one reason or another, I've seen a fair amount of overhead athletes that get some of that TOS type stuff, neurovascular compromise, different things like that, and we start them a little bit more conservatively, I'd say, when we do upper extremity BFR with them. Like, I think we're more around the 30 to 50% LOP
Okay.
instead of jumping right into the 60 to 80. And again, that's just clinically what I've done that way. That doesn't make it right or wrong, but I've noticed that they seem to respond pretty well to that. I think that a lot of the BFR effects, like you mentioned, obviously there's pain reduction, obviously there's improvements in the actual tissue quality and capacity, and it's just overall how it feels. But even just going back to some of those different vascular and neural changes for a second, like I think that it almost gives the upper extremity a stressor that it needs to adapt to the stresses of the sport. And it almost makes that like neurovascular symptom calm down a little bit because you're actually like working it and addressing it. That wasn't as eloquently said as I wanted it to be, but I think in general there's something to that concept of using BFR to actually help intervene in those that have some start of symptoms. Now, again, I think you need to be careful with it. Don't just jump right off the deep end, but I think there's something to that conversation around hemodynamic and vascular type conditions in the upper extremity and BFR.
Yeah, absolutely. I really liked your little nuance there, 30%, right? Commonly in the literature, we always see 40 to 80, 40 to 80. But again, any occlusion is better than no occlusion. And if 30% gives us everything we need, right? Let's make sure someone is getting the BFR that they need. And we can always work up later. We put on too high of a pressure, right? You never want to cause injury, but you also you don't want to scare them away. And right, you inflate it to 60, you're out the gate, like, well, I'm not doing this anymore.
Right. I think that speaks to the individualization that's required when using BFR because everyone's got different tolerance levels, right? Like there was a picture I've got somewhere on my phone when I was doing double upper extremity BFR, and I was doing I call it the Holy Trinity superset: body weight push-ups, dips, and chin-ups. And doing those three, like my arms eventually started to look like Barney because they were so purple. Now, that might have been a little extreme, but I thought it was the coolest freaking thing ever. The veins were popping and all that
Yeah.
stuff, but not everyone is going to be like that. So I think finding a way to almost like individualize it and meet people where they're at, even if it's slightly lower than what's recommended from a research
Yes.
standpoint, to the point you made, something is always better than nothing. Some stimulus always beats no stimulus. So, if they can only tolerate 30%, cool. We're going to do 30%. And I'd rather get the benefits from 30% than get no benefits.
Absolutely right. And that's something to consider when you're selecting a BFR. The width of that cuff is going to vary that pressure that's applied. I've used a variety of cuffs now, the pros and cons, right? A wide cuff, we're going to include blood pressure. We're going to include blood flow at lower pressures, which is great. But when the cuff's really wide, it's going to sit right over that muscle belly and makes those contractions more challenging. It's tougher to get a full contraction, bicep, hamstring, tricep. Those thinner cuffs, right? The more of those BFR straps we see now on the market, they're about 5 centimeters wide. They got to have an exponential increase in pressure to include the same amount of blood flow as those wider cuffs. Pro to those, they're going to give you great range. We're going to get a great muscle contraction. A con, and one thing that I really noticed, caused quite a bit of bruising. I don't bruise very easy, or at least I played college football. I've been battered, beat around a lot, haven't had a history of bruises, but using those thinner cuffs, I looked down, I was purple above and below. So there's something to be said about this. The strap width is very important.
I would have to agree with that, and it's funny because 'cause I've noticed similar things as well, and I'll get some bruising every now and then up around my, shoulder that way, kinda like around the front deltoid, if you will, that way, and it's interesting because a lot of people listening that work with athletes probably think, "Okay, like, they're gonna bruise, it'll go away in a few days, who cares?" This is a weird little quirk, but it's one that I picked up working with a lot of high school athletes, is they didn't wanna do any type of manual cupping, dry needling, anything that could run a risk of discoloring their skin around times of, I don't know, picture day, media day, school dances, all these different things. They were very, very guarded about that stuff. So naturally, I don't want BFR to fall into that same category for them. And again, it's one of those weird little nuanced things that maybe we as clinicians don't think about. But, if you're working with an athlete where the cameras are rolling and they're on TV and they're all over social media and that sort of thing, those things might be going through their head. And, discoloration of skin is not something that they might want to be sharing with the world.
No doubt, or even mom, dad, you're working with the older population. They're not going to want to be all bruised and battered when they leave PT. Right? They want to be, I want to be feeling good, want to be looking good, and having all those positive vibes. So I think that's very important to to consider when we're working with those patients.
Yeah, absolutely. Make them want to come back and do more. And you mentioned that earlier, even in relation to the 60% limb occlusion pressure usage, right? Like athletes were excited and wanted to come back doing it at 60, 80%. Maybe they felt a little too beat up. So I think ultimately, as long as you're within those ranges to get adaptation, like if you're living within those ranges, that's what it's all about at the end of the day. And I think the other piece that comes to mind for me as well is I know that there's been some different protocols going back to what we talked about early on about just like conditioning the neurovascular structures for some of these different like ischemic environments. I know we mentioned the tourniquet, but I mean, there's other times and other cases where, hey, the athletes are going to be in altered circulatory states, if you will, that way. Outside of the 5x5 passive protocol, do you have anything that you typically do to help kind of drive and deliver those hemodynamic ischemic type benefits using BFR that way?
All right, so pretty standard. We'll go recommended 5 minutes on. Then typically it's 5 minutes off for 3 cycles. And passively, lower body, we're going 100% LOP. Upper body, we're usually between 40 and 60, to be quite honest with you. Now that off time, we can bring that all the way down to 1 minute, 5 on, 1 off. If they're well experienced with BFR, we're shorten that time frame. Commonly, always that 75 rep protocol. You see it a ton in literature, that 30, 15, 15, 15. There's a 2024 meta-analysis systematic review. I know Brad Schoenfeld was on it. I don't remember all the authors, forgive me, but they did a hypertrophy rep analysis, and they found that multiple sets of 15 were just as effective as that 30, 15, 15, 15 protocol. So that's something I strongly believe in. That's what I really subscribe to. So I felt having that first set of 30, if I'm working with someone who's never done traditional strength training and who has never done BFR before, and I'm asking you to hold great technique for 30 repetitions, come on now, right? Like that's just setting some, that's very hard. That's very hard to do. I'm almost setting that person up for failure. So I want to assure we have great form, great technique. And I think bringing those reps down can be very helpful. Back to what you said about the occlusion, one thing I want to touch on, you read multiple studies out there between 40 to 80%. Some studies have reported, right? There are differences and slight differences in growth hormone, testosterone, insulin growth factor release. However, the outcomes, increases in muscle strength, size, the hypertrophy effect, relatively the same. No significant difference between those pressures.
Yeah, absolutely. And I think one of the other things that comes to mind as well that I don't think we've talked about it yet is going back to that cardiovascular benefit side of things. And again, you mentioned it, how this can benefit individuals across the lifespan, not just athletes. But I believe, correct me if I'm wrong, but the BFR like cuff and placement and using it in some of these different protocols we've discussed, there's some research to suggest it activates the metabo reflex, which jumps up the sympathetic nervous system like haywire that way. So from a standpoint of, I talk about it in relation to redlining or throttling up that way. Like this is such an easy way to teach athletes how to redline and throttle up. But at the same time, you can use it in passive ways to also teach them how to throttle down, if you will. And I think that there's some kind of lost art in being able to have that metabolic flexibility of going to an absolute red line from a heart rate standpoint to going all the way down to a super low and slow rest standpoint. And I think that applies to individuals across the lifespan, not just athletes, but you look at the stats around cardiovascular disease, and obviously whatever we've been doing to help address that is not working as the numbers continue to rise. And I just can't help but wonder if there's potentially some kind of application for this and with that outside of just the conditioning stuff that we've discussed so far.
Yeah, I think sorry, I had a timer going off. I had to adjust for that. I think you're spot on. The cardiovascular effect. I just posted a study on LinkedIn today, like a little quick review, a little summary. Cardiovascular effect in older adult population. I think that's what BFR walking does. Something so simple, so unstressful, so to speak, but it really just, it makes it, I mean, it stresses the system out by changing the way that oxygen is flowing into the limb. You're making it far more stressful to that lower body. So you're not doing very hard work, but the body's perceiving it as this incredible intensity, so it responds appropriately. And I think we have some people now, there's studies that are coming out that are using high intensity training with BFR. And I think that's where you can kind of see like that red line effect, where they're going to be right there. Maybe they're squatting heavy 5x5, and they're actually going to put the BFR during the rest period. And so they're really taking it to the limit. Now we have that maximum effort 5x5 higher, 80, 70, 90% range of our 1RM. And then when we come off that rest, instead of just being able to fully recover, we're putting on the cuffs and we're occluding. So now you have that. We're really challenging the system in that regards while still getting that heavy stimulus for the CNS.
Do you ever occlude all 4 limbs simultaneously, or you just leave it to 1 or 2?
Always 1 or 2. No recommendation. I always want to it's either on 1 or 2 legs, right? It's always always that most proximal portion of the limb, right? So even if I'm working my elbow or my wrist, I'm always going to put it as high in that arm as possible. And it's always going to be 1 or 2 arms, never arms and legs at the same time.
Right. Now, what do you feel like has been one of the more or most unique applications of BFR that you've seen that way, whether that's yourself or someone that you're working with that way? Any kind of unique cases or unique uses that you've seen that you're like, I never would have thought of that?
Yeah. So BFR walking recently had a football. Speaking with a football athletic trainer, and he does a lot with BFR. He does some really interesting stuff. So I love to pick his brain. I had some guys who've had hand surgery, so they can't sweat, or they do not want them sweating right now. So doing a lot of BFR walking or just some light load stuff with them. But I thought that was a nice little answer to can't sweat. Passive recovery on the lower body post concussion, right? So BFR boosts brain-derived neurotropic factor, and we know that lactate, which used to be like the devil, Satan over here, now is, we know that it's being shuttled to the brain, and the heart will use lactate um, in certain instances as fuel. And so post-concussion, they're finding, right? It's not a published study. This is anecdotally, but there are multiple universities now, different programs, pro sports teams. They're using passive BFR on the lower body post-concussion. They're finding that um, the results they're testing better, sooner, faster.
Yeah, no, that makes a lot of sense when you break it down like that. And I think it comes back to knowing the underlying physiology and knowing how you intervene with exercise and modalities to have a positive impact. And I think a lot of times we forget about that. And I'm guilty of that to a certain extent myself, right? Like you listen to some of these different things when you're in your undergrad physiology lectures and you listen to, the Bohr effect and all these different like oxygen hemoglobin dissociation curve. And you're like, when am I ever going to use this? And
Yeah.
then you come full circle as a clinician or a coach, and you're like, "You know what? This is actually really important, and I should go back and brush up on it a little bit." But I think the more you understand the physiology, like, I don't wanna use the term biohack, but I'm gonna use the term biohack. Like, you're able to almost, like, hack it from an interventional standpoint and intervene with things to drive the physiology changes that are needed to promote healing to any one of, the countless different injuries we see. Because athletic injuries and even injuries in the older adult population are not getting simpler, right? I had a athlete last year. Unfortunately, we couldn't use BFR with him due to the surgery site in nature, but he had bilateral adductor repairs at the same time. So naturally, obviously, we can't do anything with the leg BFR, but it's like, looking at that, it's like nothing prepared me to rehab this as a non-clinician. Like you just kind of have to jump in and figure it out. The problems we're trying to solve are inherently extremely complex in nature. And if we don't understand some of these unique ways to problem solve, then ultimately we're doing a disservice by the athletes that we work with.
Spot on. I recently posted, I was on LinkedIn and then in the classroom where our certification lives, but BFR, and it's cliche, but biohacks the Henneman size principle theory, right? Which says we're going to recruit smaller motor units, right? Those type ones. Then as load gets heavier, intensity increases. Now we got to go to type 2 fibers. Well, basic physiology, right? Bringing back, I taught biology for many years. Um, Type 1 muscle fibers, aerobic, need oxygen, right? Slower twitch, more like marathon. Type 2 muscle fibers, would keep it real simple, right? Anaerobic, don't need oxygen, high force production. They're going to get stronger, faster, hypertrophy. Well, as soon as we reduce oxygen in that limb, that body no longer, that's what makes BFR so effective, right? That body's no longer, those muscles can no longer call upon those type 1 muscle fibers to that extent because there's no oxygen available. So now we're able to get those type 2 muscle fibers involved much earlier with much lighter loads. We reduce, right, the joint stresses, we reduce any of those stresses overall felt by those things, and we're able to get those muscles working to improve that hypertrophy with incredibly, body weight exercise.
Absolutely. On one hand, just thinking about the rise in this sports science culture that we live in, I like to think that Goodhart's law holds true to the end of the day, in that we start to assign measures as targets. Like, we have to hit this, we have to hit that. We see it in rehab all the time, but I think when we start to do that, it becomes less of a good measure, if you will. I think about some of these different ACL targets, right? Oh, we have to hit 90% symmetry with this. We have to hit 90% symmetry with that. And as a result, a lot of clinicians, and I'm speaking from experience because I did it myself a couple times and I caught myself. I looked at myself in the mirror and I was like, this isn't right. You end up kind of pull from Common Core education, if you will. You end up teaching for the test, right? Like, hey, we need to get better at the triple hop. So what are we going to do? We're going to triple hop over and over and over again. And I think BFR as a tool and implement can almost kind of like counteract that effect, if you will, because it's like, hey, we need to get better at, okay, hopping. So I need better muscular power and I need a more efficient muscular system. Okay, I can do that with BFR. I look at the knee extension testing in particular following ACL, and I felt like a lot of the numbers we got were faulty in the sense that pain was the limiting factor. Hey, I've got tendon pain when I'm doing the Biodex. I've got tendon pain when I'm doing the max isometric knee extension test. What can I be doing? I think including BFR earlier in the rehab process helps to mitigate a lot of those issues that we see later on in this like assessment driven world that we live in. And, as a result, kind of prevents you from becoming someone who just intervenes to get a better test score, because it's not just about the test score at the end of the day. It's about, is the athlete truly ready to return to what they're trying to return to? And if you just teach for the test, I like to think that your results are a little bit skewed and misguided.
Yeah, I completely agree. I was working with this athlete, had an ACL reconstruction last fall. Significant. I mean, he was ready to go PT wise, was cleared, run out of sessions, went to his 9-month return to play. Still had significant atrophy, was not anywhere where I thought he should be. And I was like, I know you got this return to play. But I would be cautious. I would do, take a day off here and there. Let's make sure we're not fatigue setting in. Poor gentleman went up again. It was a non-contact ACL tear a year ago, non-contact ACL re-tear, just in the past couple months. I think it's very right. Yeah, we're trying to check those boxes, but it's gotta be done. We gotta make sure the kids are safe, especially a young person, right? They cannot be going to have two ACL reconstructions in the same leg by 19, not ideal, not what you want. Like, we have to make sure that these kids are getting proper care. It might be a little devastating, but I think it's more important to have that hurt now. Like, hey, you're not going to be ready to start a football season. We might get a month or two in, and you'll be able to play. But right, we're in such a rush to get people ready to go and to tell them, hey, you can go back. You're going to be back for next season. But then end up, you might cost them that season, or cost them right then. You're talking down the road. What happens down the road? Right, you're snipping the meniscectomies here and there, and then ends up becoming a total joint, right? And then there's just nothing left, arthritic, all that stuff.
Even to your point on the atrophy, right? I've seen athletes who are still atrophied visibly get fitted for functional braces that ones
Yes.
that cost about $1,200. They're custom, meaning if your quad grows more, it no longer fits. So if you haven't restored symmetry in the actual bulk of the muscle prior to that, odds are they're going to be shelling out another $1,200 to get
Yep.
another functional brace because the muscle wasn't as big as it should have been. And again, going back to the point you made about some of the higher volume protocols using BFR for hypertrophy and stuff, it's like, start this early so it's just not an issue in the future that way. Building off of that, I've seen anecdotally a rise in the amount of knee cartilage injuries, especially in the athletic population. In basketball and tennis, we've had a number of athletes on the podcast that have had knee cartilage defects. And that was something that I felt like, from a sports rehab standpoint, wasn't often discussed. Has there been any applications that you've seen from a BFR standpoint for the individual that might have cartilage lesions or cartilage defects that way?
Yeah, I mean, we still see a lot of isometric work, a lot of passive BFR commonly recommended, right? Boost that growth hormone, insulin growth factor, testosterone, those healing effects on the cartilage, the tendons, the ligaments. Depending on what is tolerable pain wise is kind of what's being recommended. But my go-to always starting off, right, a tendinopathy. I'm gonna hit some passive BFR with you. I think that IPC, whether going into exercise, passive BFR cannot be beat. And what I mean by that is when you do it before whether it's a game or maybe you're just going in to train for a heavy session, it's going to offset fatigue. Like there are multiple studies support lifting might be minutely heavier loads, but heavier loads for more repetitions by performing IPC beforehand. It's going to offset that fatigue, boost those recovering hormones are going to be right. Those are going to be circulating right out the get go. I think there's a huge application for that. It calms down the pain, right? The nervous system, giving that different signal, kind of disrupt the pain you might have from that destruction of that cartilage. I think a lot of it, getting on my soapbox here, the specialization of these athletes, right? Like general physical preparedness, GPP has gone out the window. And now we're seeing kids, that's great, you're 12 and you can throw 80 miles an hour, but you can't box jump or sprint. What are we setting these kids up for, right? Just an absolute disaster. And then you're talking about how the kinetic chain, right? It's changing the way they're, right? It's throwing up, we're getting pelvic tilts, leg discrepancies. It's just leading to this whole laundry list of different issues where we just need to be with these athletes. I think we'd alleviate a lot of problems with general physical preparedness. We're going to get you moving in a lot of different directions. You're going to be performing a lot of different exercises, different modalities, different weights, stimulus, whatever it is, bands, kettlebells, dumbbells. We're going to get you moving a lot of different ways, running and jumping. Being kids again, I think would alleviate a lot of these issues that we're seeing, to be honest.
I 100% agree. And just to kind of expedite that whole process, because sometimes you get an athlete that's 17 and doesn't have that GPP base. And it's like, hey, we have a very tight window to work on this with. One of the things that was shared in a past podcast was a 1x20, one set of 20 reps, just a ton of different exercises. Like, hey, we're going to do 3 different lunge variations. We're going to do 3 different squat variations, one set each, just a way to try and get them moving in a lot of different ways. And I just couldn't help but think as you were talking, if the athlete has their own set of BFR cuffs, whether they buy them purchasely, rent them from a clinic, whatever it is that way, they're able to do something like that 1x20 realistically every day. If you do low load BFR, one set of 20 of a bunch of different body weight movements, to me, that's not going to put them at risk of overtraining or overreaching or anything like that. It's a pretty low stimulus. In fact, it might even help them from a recovery standpoint. But the overall movement variability and the expansion of the movement vocabulary that you get from that is well worth the 10 minutes that it takes to do 6 or 8 different body weight exercises, one set of 20 every single day. It's just, to me, it's low hanging fruit. And it's like, just grab it and apply it, because that's only going to help your athletes.
Yeah, completely agree. That's a great point, right? Got I'm all saying, right? One day we're doing upper body, one day we're doing lower body. We're just doing a bunch of lunges, right? Forward lunge, backward lunge, lateral, curtsy, challenge those hips, that low back, those glutes, spot on. I think that would be hugely helpful. So if you are an athlete, and while you can, a lot of them now, you use HSA, FSA funds to purchase your cuffs, which is very helpful to most people, some of those pre-tax dollars. But now you don't need all that expensive weight. You don't need all the expensive weights. You don't need a bench or a squat rack in your garage. Let's just if you need it, a dumbbell, get one of your 1 gallon milk jugs, fill it full of sand. You put on an upper body BFR cuff, you're going to get more than enough stimulus to get some muscle growth, lifting just things around the house.
Absolutely. Michael, I feel like we can probably talk about BFR and the seemingly endless applications of it all day long that way, man. Is there anything we missed as we were discussing today, or anything else you wanted to share?
No, we touched on a lot of it, right? The strength training, the aerobic, the passive BFR. I think when I speak with a lot of our older populations. And just so this is floating out there in the ether, right? The mitigating fall risk, the improving balance with blood flow restriction. We got individuals suffering from sarcopenia who can't put on muscle mass. BFR is an answer. Type 2 diabetics, BFR is going to help, right? Not only put on muscle mass, but it's going to give that glucose somewhere to go. It's going to get forced into those muscle cells. So a huge, huge benefit to those people out there if they would just could get their hands on just some education, some information. We can help out a tremendous number of people.
Building off of that for a second, one of those, again, going back to that term that I just love, biohacks. I've seen a lot of biohackers, if you will, promote exercise, something light right before or right after a meal, maybe like a walk or something.
Yeah.
Is there anything about the use of BFR timing wise, right before or right after a meal to help change that blood sugar response and so on from eating that way?
I would most definitely, and I do it, and I really enjoy it, is if I'm not too tired, right? We got youth sports, so sometimes we're eating dinner at 8, 9 o'clock. But after dinner, I like to put on the cuffs and go, I'm only, maybe 10 minutes, a 10-minute walk. But, you get that occlusion, it basically you're squeezing everything out of that muscle cell, right? And then that occlusion of that cuff comes off, and it's like a sponge, and it's just going to suck up all of that glucose, all that nutrition that you just put in the bloodstream from all that food you're digesting. So BFR walk, post meal, absolutely.
Even
Absolutely.
just the cognitive benefits alone from that, because I know a lot of people tell me, especially after lunch, that little glucose crash that they get in the
Yeah.
afternoon just crushes them. Excuse me. And I couldn't help but think, like, man, like that could be a potential, again, little hack to mitigate that. I love that. Michael, for people who want to find out more about you, keep up to date with all the stuff that you're doing in the space, obviously check out your course and that sort of thing. Where can they find you at?
Yeah. So website's clinicalbfr.com. You can find me on Instagram, clinical BFR. Our sports performance facility is Great Lakes Sports Medicine and Performance. We're located in St. Clair, Michigan. And then on LinkedIn, you can search me, Dr. Michael MacPherson. I post BFR or just type in blood flow restriction hashtag, and I'm sure you'll see me somewhere. I post breakdown summaries of articles every day and everything I can find just to put more information out there to help people.
Yeah, no, that's awesome, dude. We'll link to all of that in the description below as well. That way, if you didn't quite catch it, you can just click there and see everything that Michael is up to. This was awesome, man. Really appreciate your time and everything you're doing.
Yeah, Dan, thank you for having me. Really appreciate the opportunity to talk and just hopefully some people get some positive things out of this.